evening, everybody. Good evening, everybody. As is the tradition, we have faculty lectures from time to time, and this time it's my turn, and I'll be speaking on surgical nutrition. So, to start off, let us. This is the definition of malnutrition, actually. So, I have given the reference below. Basically, it is either lack or excess of energy intake or deficiency or excess of macro and micronutrients. So that is the definition of malnutrition. So though the author claims that there is no single acceptable definition for malnutrition, but this is probably the closest. So there are three broad categories of malnutrition, which is undernutrition, which is the where the patient or the person concerned will have reduced intake of nutrition or reduced absorption of nutrients, and hence will not be able to meet the metabolic demands of the body. So that is undernutrition. Or you can have, even if the patient is managing to eat reasonably, will have micronutrient deficiency or sometimes excess also. For example, people taking lot of calcium, vitamin D, we can have hypercalcemia and vitamin hypervitaminosis. Even hypervitaminosis A is also known. So you can have micronutrient excess also. And then another very common problem is overnutrition, which is either overweight or obesity. And then the startling statistic is among the population that is screened, actually, 27 to 50% of patients are malnourished. But I will also like to add another starting statistic that when these are statistics from advanced European countries, how often do the patient gets nutritionally screened? I'm not talking about nutritional assessment. Nutritionally screened, Germany, which is one of the most advanced countries, it was about 27%, and across Europe it was about 35 to 40%. One study from United Kingdom said that the nutritional assessment was going on in surgical wards in about 95%, which is excellent. So generally, the surgical patients, nutrition is neglected. That is the overriding message from that particular statement. So now let us come to the Aspen and Aspen guidelines as to what has to happen with nutrition. So this is the 2023 statement from both Aspen, joint Aspen and Aspen statement. For the uninitiated, Aspen is European Society of Parental and Enteral Nutrition, and Aspen is American Society of Parental and Enteral Nutrition. The two large bodies which usually dictate and dictate the nutritional status across the globe, so to speak. So the first guideline is nutrition has to be integrated into the overall management of patient. So what happens is we have preoperative assessment of the surgical condition, preoperative assessment of the general condition of the patient, and specifically, for example, patients with COPD, patients with renal impairment, patients with cardiac impairment. You assess all those things, but nutritional assessment is not generally part of the preoperative assessment. So that has to become integrated into the preoperative assessment and overall management of the patient. Then the next caveat is avoidance of long periods of preoperative fasting. So that used to be the norm, that patients would be fasted fasting the previous day, and many times from midnight for the next day surgery. So that practice has long been given, should be given up. Still, many surgeons practice it, but slowly, among the tenets of enhanced recovery program, one of the main requirements would be a preoperative carbohydrate rich drink 2 hours before surgery. It should be clear fluid, and that is now been, I think, accepted and practiced across many countries, and certainly across many places in India too. Early establishment of oral or enteral feeding immediately following surgery. That is another important caveat, which I think has again part of the ERAS program, which has made significant inroads into the psyche of the surgeons and has paid rich dividends for because of that. And nutritional therapy, this means we are not talking about supplementation, we are talking about therapy. So that is, if the patient was assessed preoperatively and was found to be at risk or malnourished, then nutritional therapy has to be initiated preoperatively, intraoperatively, and postoperatively. And if the patient was borderline before you started surgery, especially if it is semi emergency or emergency, then nutritional therapy should be initiated at the first instance immediately following surgery and continue till the patient recovers. We all know very well that nutritional status of the patient is an independent risk factor for post-operative complications, including infective complications and otherwise, and also one of the important indicators for prolonged length of stay in the hospital or ICU stay. And I will also go as far as to say in terms of mortality and significant morbidity as well. So nutritional status of the patient is an independent predictor of patient's recovery and also one of the recognized risk factors for post-operative complications. Another important aspect of the SPEN guideline is metabolic control. See, it is definitely known to all of us that immediately following surgery, there is a term called insulin resistance. This starts immediately after surgery and can last anywhere up to 4 to 6 weeks following surgery. Majority of the patient, it lasts 7 to 14 days, but it can last longer also, especially in diabetics. So metabolic control means that glycemic control in the perioperative period has to be maintained. The other aspect of this is that in a large study from Netherlands, especially the cardiac patients, they try to do what is called as stringent glycemic control. That is minute to minute measurement of sugar and then adjusting the insulin infusion accordingly. But they have shown that that kind of rigid euglycemic control is neither contributing to the patient's overall recovery and survival, and it is probably very cumbersome and not necessary. So suffice it to say that you have to maintain a reasonable euglycemic status of the patient, which will see, what we have to realize is apart from insulin, there are all other hormones in the body, including the growth hormone, the thyroid hormone, the thyroxine, the corticosteroids, adrenaline, noradrenaline, glucagon, all of these causes hyperglycemia. So insulin has to bring down the sugar, and there is peripheral resistance to insulin in the post-operative period. So that is why it is important to try and achieve euglycemia in the perioperative period. And reduction of stress. Reduction of stress has to start preoperatively. The patient has to be counseled about the operation that he is undergoing, the possible course in the hospital, the probable complications, and then you have to reassure the patient that the surgeon concerned and his team or her team will take all precautions and measures to make his stay in the hospital comfortable, and we will explain every facet of surgery and the post-operative recovery to him in a language known to him or his own mother tongue, which will make the patient less stressful, because surgery is a major uh, life threatening exercise. Even a minor, there is nothing called a minor surgery. Complications can happen even with minor surgery. So hence the patient will naturally have fear and apprehensions, and it is our duty to make him lose those fear and apprehensions and make him comfortable in the hospital. So reduction of stress is an important aspect, and early mobilization of patient. I will come to this in a bit more detail, but this facet has to be stressed upon, because sarcopenia is a very significant risk factor in the perioperative and postoperative complication of the patient. So we now come to what is called as prehabilitation. Can I have already written it there. Nikita, would you like to tell me what prehabilitation is?
Sir,
Because this
optimizing the
yeah,
patient before surgery, sir. It's
yeah, optimization of surgery before the surgery happens. So it is considered to be a tri-modal approach. I'm sorry, because the topic is very vast, I will have to rush through this. So in between, please interrupt me if you have any questions. Otherwise, I will continue.
Sir, I have a question, sir.
Huh?
Sir, I have a question, sir. Regarding the carbohydrate.
Hello, I'm not clear. You're not clear, Nitya. Hello.
Yes, sir. No, not able to hear Nitya, sir. Is for the
Yeah, what we'll do is we'll stop in between and then stop for questions. So I will carry on.
okay, sir.
The trimodal approach is, one is the nutritional assessment and therapy, which is you have to first, there is something called nutritional screening, then nutritional assessment, and then therapy for patients who are at risk or already very malnourished. So that is very important. Then physical exercise. So you have to tell the patient to exercise regularly before surgery. That is, walking or gentle exercises to be done at home. You can even teach them, send them to your own hospital physiotherapy and gymnasium department and ask them to teach them, breathing exercises and also exercises to improve the muscle fitness. And the third one is, as I said, stress reducing psychological component. So the stress reduction is an extremely important aspect of it, because stress will increase the insulin resistance, and also it will have a negative impact on the post-operative recovery of the patient. So important thing is for informed consent, counseling the patient, and in the Western countries, what they do is there are specialist nurses, in each department, who will actually go home of the patient and and assess the patient's living condition, and make them comfortable there and explain to them what will happen in the immediate post-operative period, and when they come home, how will they support them. So there are a lot of these questions and uncertainties in the patient's mind, which has to be addressed before the patient goes for surgery. So a patient who is cooperative, who is trusting you, will make a good patient who will definitely improve in the post-operative period and go home, rather than a patient who is already very stressed out. So these are the three modes, that is nutritional assessment, physical exercise, and stress reduction. Multiple meta-analysis uh, of this approach has shown that there is significant reduction in post-operative complications and length of stay. They say something up to 35% reduction in complication rates, and 2 to 3 days, I'm talking about longer operations, 2 to 3 days reduction in length of stay of the hospital, which is a very significant reduction. So now let us come to sarcopenia. And does anyone know what the definition of sarcopenia is? Praveen? Nikita?
Sir,
Praveen?
sir, it's a degenerative condition. So there will be a loss of
Not degenerative. Nikita? Ainas?
Sir, it's chronic wasting
Loss
of
of-
muscle, sir.
Yes, sir. Like loss of muscle mass and the
Correct.
functioning,
Correct.
sir.
Loss of muscle mass and muscle function. Correct. That is the definition. So basically, what is important for all of us to know is sarcopenia is very grossly underestimated, especially if the patient is obese. You think the patient is healthy, but he is not. Not only is the patient obese and the patient has excessive fat, but the patient has lost a lot of muscle mass in lieu of the deposition of fat. So there is another term which I have actually forgotten. Anyway, when I remember it, I'll tell you. Basically, that what happens is, if you go through the perioperative and postoperative period, it is said that a patient who has been immobile for a period of 24 hours loses 3.3 percentage of his muscle mass, and for 2 days it is about 5.7%, and about 15% in a week, and in 2 weeks 33%. Can you imagine this, the magnitude of this muscle mass waste, especially quantified by loss of quadriceps? So that is where you actually, even in well-built athletes, we are not talking about patients who are weak and elderly. We are talking even about athletes who are very physically fit and very active. So it is important to maintain physical activity. That is why early mobilization of the patient is extremely important. And if early mobilization is not possible, we have to address that issue by passive mobility of all the muscle groups in the immediate postoperative period. So sarcopenia and malnutrition is grossly underestimated, especially because, especially in obese patients, you think the patient is actually okay, but the loss of muscle mass is very significant in such people. In a meta-analysis of 7,179 patients in 29 studies, perioperative nutritional supplementation, the sarcopenia and malnutrition was, this is meta-analysis of 7,000 patients, and which has shown that this is a very significant problem. And perioperative nutritional supplementation of 6,370 patients in 56 trials showed reduction in infective and non-infective complication and length of stay of the hospital. So all of these say that nutrition is very grossly neglected, and whenever the matter is addressed properly, you can see the benefits. So I will now go through about a few of the guidelines which I think is important. There are about 36 guidelines. Out of these, 6 guidelines are relating to transplant, which is probably beyond the purview of our class this time. And there were 30 guidelines, out of which I have chosen a few, which I think are extremely important. So these are recommendations by both ESPEN and ASPEN. And I think the article which I have quoted, that contains all this. So first is there is no need for preoperative midnight fasting. So patients need not be fasted from midnight uh, of the previous day of operation. So this is level of evidence A. See, what they have done is, this is a consensus group of ASPEN and ESPEN experts of nutritional experts. And what they have done is they have actually given level of evidence, level of recommendation as A, B, and C, and also they have quoted how many, what is the percentage of congruence, which is percentage of people agreeing with this recommendation. So many of these, the agreement is between 95 and 100%. So not only is the recommendation very high, but there is also significant agreement among the experts. So these are based on perusal of all the current evidence, many randomized control trials and very good studies which have addressed this matter. So these recommendations are very strong. Next one is the clear carbohydrate fluid 22 hours before surgery reduces the post-operative insulin resistance and length of stay. Again, no, not much doubt about this. This is a very, very good study from Karolinska University from Stockholm in Sweden, where they have proved that giving 200 to 400 ml of carbohydrate drink 2 hours before surgery will significantly reduce the post-operative insulin resistance and also length of stay. Post-operative nutritional intake to start or to continue at the earliest. Again, level A evidence on this. So that means the ERAS protocol, I have to stress to all of you, has been studied with great detail in across all specialties: upper GI surgery, hepatobiliary surgery, thoracic surgery, colorectal surgery, pancreaticobiliary surgery, gynecological and oncologic surgery, urologic and oncologic surgery, and cardiac surgery. So I have enumerated all the surgical specialties and subspecialties, and ERAS protocol has been evaluated very stringently across all these specialties and has been proved to be useful and successful in all of them. See, you think that esophageal and gastric surgery you should not feed the patient, but they have started oral feeds in these people also with no increased complication, leak, or anything like that. So that is why post-operative nutritional intake has to start at the earliest. Some patients, for whatever reason, all of these things have to be customized to the patient. But general rule of thumb is don't withhold oral intake in any patient unless there is a strong reason to not feed them. So that should be your guiding principle. Nutritional assessment and perioperative nutritional support is mandatory. Again, level A evidence for this. Next, coming to contraindications for early enteral feeding. Again, this is level A evidence. Intestinal obstruction and paralytic ileus. Severe shock. Severe shock, the reason is because there is significant fluid shift and electrolyte imbalances in these patients, and patients are, many of them are on noradrenaline and adrenaline, which will reduce the visceral, you know, the visceral splanchnic blood flow. So by feeding them, you are actually, it may not be absorbed, and many of these people may have an ileus to go with it. So, and then there is also subliminal ischemia of the bowel also because of the significant splanchnic vasoconstriction. Hence, it is not advisable to feed these people. Intestinal ischemia for obvious reasons. High output fistula, again, this is a relative contraindication. Once the fistula output has been stabilized and the fistula anatomy has been studied, you can feed the distal end of the bowel through what is a mechanism called fistuloclysis, where the fistula fluid that comes out is strained, collected in a sterile manner, strained, and then you can even add other supplements like the semi-elemental and elemental diet to the collected fluid that comes from the proximal limb of the fistula, and by ensuring that the distal gut anatomy has been studied properly and no strictures or leaks are there in the distal end of the fistula, you can cannulate the distal end and then feed the patient of the effluent that comes out from the proximal end along with the semi-elemental or elemental diet, and this can reduce or completely supplant the dependence on parenteral nutrition. So high output fistulas is a relative contraindication. Severe intestinal hemorrhage for obvious reasons. If oral or enteral intake is less than 50% of the total energy expenditure, then you should consider parenteral nutrition. So this is again a level A evidence. Now coming to, say, I'm not going to go in detail of immunonutrition, which we will do in the next class, but this is again continuing the recommendations of the ASPEN and ESPEN. Immunonutrition with glutamine. Glutamine is considered to be one of the front runners in immunonutrition. So is arginine, and but they alone are not sufficient, and there is no evidence of any benefit if they are given alone. So that is level A evidence again. Omega-3 fatty acids with in the perioperative supplementation is beneficial in reducing infective complications and also ICU stay and length of stay in the hospital. So omega-3 fatty acid seems to have some definite benefit in the patient recovering in the post-operative period. The decreases post-op, as I said, decreases post-operative infection rate and also length of stay. But what happens with these kind of patients is, especially patients who are very sick, there is significant heterogeneity in the data and also in the patient population. Because the patient population is a mixed population, strong recommendations cannot be made based on some data alone, because what applies to one group of patients may not apply to another group of patients, and what applies to patients who are in ICU may not apply to patients who are on the ward. So there is heterogeneity, and hence the recommendations have to be taken, especially about omega-3 fatty acids, with some trepidation. Preoperative nutritional assessment and therapy in severe risk patients for 7 to 14 days reduces mortality, morbidity, and length of stay. So it is mandatory to have a preoperative screening first, and then preoperative assessment in those high patients who are at risk or patients who are already malnourished. You have to have a detailed assessment of them, and then you have to initiate preoperative nutritional therapy. We are not talking about supplementation, we are talking about therapy, and that will ready for, and that has to be continued for a period of minimum of 7 days, and if possible up to 14 days, in especially in elective setting. So and then that is shown to reduce the mortality, morbidity, and length of stay by up to 35%. I think that is a very significant statistic. Oral supplementation of arginine, glutamine, omega-3 fatty acids, and ribonucleotides as a combination in all patients, not only patients who are nutritionally at risk or malnourished, but across even patients who are normal, is shown to reduce post-operative complications and length of stay of the in the hospital. So no point in giving them individually, but if you give it in combination, it may help. And then the next recommendation, which we all know, is whenever gut is working and it is feasible, oral or enteral feeding is preferred. So that I think all of us know. Oral nutritional supplementation in patients who do not meet the energy needs, especially patients who have cancer, patients who are sarcopenic, and elderly patient, supplementation is definitely necessary. If, for example, the patient is not eating well enough and not meeting their total energy expenditure, then nutritional supplementation is mandatory. Again, level A recommendation. Preoperative TPN or parenteral nutrition. The difference between total parenteral nutrition and parenteral nutrition is, when parenteral nutrition is supplement to enteral nutrition, then it is considered as just parenteral nutrition. But if the patient is unable to take any oral fluids or nutritional requirement, or if the patient is not absorbing that, in such patients you may have to give total parenteral nutrition. That is, the entire energy requirements and energy expenditure of the patient is taken care by parenteral nutrition. That is called total parenteral nutrition. So if the patient is severely malnourished and the gut cannot be used then or ineffective, then at least for a period of 7 days, total parenteral nutrition or parenteral nutrition as a supplement to enteral nutrition should be done. But there are studies which show that it can go up to 14 days, but no significant improvement beyond 7 days is shown. So that is why it is said that you have to give TPN or parenteral nutrition for at least a period of 7 days. Then early enteral nutrition to be started within 24 hours. Again, level A recommendation. So this I have already stressed upon. So this is again extremely important. Use the gut as soon as possible. So we always start patients 2 hours after surgery when the patient is fully recovered from the anesthesia and not at risk of aspiration or vomiting. You start them on clear fluids and gradually step up. Placement of nasojejunal or feeding jejunostomy in major abdominal surgery, especially gastrectomies, pancreaticoduodenectomies, liver resections, esophageal resections, such patients, it is important to place a nasojejunal feed beyond the anastomosis or a jejunostomy surgically or laparoscopically created jejunostomy. Again, level B evidence for that. Another important thing is start feeding through the jejunostomy or gastrostomy slowly at a rate of 10 to 20 ml per hour and reach the full nutritional level slowly as per the patient's general condition, tolerance and response. For example, we usually say after every 2 hours you have to aspirate and see. If you are getting back everything that you have put in, then obviously the patient is in IES. So there is no point giving, escalating the fluid that you are giving. So you have to monitor the patient and according to their tolerance and response, you customize feeding them. Some people you can step it up within 24 hours to their full requirement, which is about 100 to 150 ml per every 1 to 2 hours. So that some many patients will actually tolerate. Some people you may have to go a bit more slowly. So that is what is called as customization. Long-term PEG or PEG to be placed if nutrition requirements is beyond 4 weeks. Again, level B evidence for that. So this is about the Aspen guidelines for perioperative and preoperative and postoperative nutrition. So these are about 30 recommendations were made. I have chosen the ones which are relevant to us. Now, what Aspen guidelines before I go on the Aspen guidelines for nutritional assessment, I will stop and ask for any questions or clarifications. Is whatever I have said so far clear?
Yes,
Hello?
sir.
Yes, sir.
Yes, sir.
If there is any doubts or any clarification, please let me know. Shall I
Sir,
continue?
sir, this preoperative carbohydrate loading,
Ah,
will that be a concern for intraoperative hyperglycemia in a diabetic patient, sir?
no,
Suppose the
it is
patient is
not.
diabetic, it is
It is
not.
not. It is not. See, the thing is, what is important is you give them carbohydrate load of 200 to 400 ml irrespective of their diabetic status.
Okay, sir.
However, you have to obviously monitor their sugars and give them insulin accordingly.
Okay.
In normal patients, you don't have to give them insulin. That's all. But
Okay.
but what is definitely sure is by giving them preoperative load, you are
Okay.
actually reducing the insulin resistance. I will come to the mechanism later, but that is what
Okay.
happens.
Yes, sir.
So,
Okay.
Sir, Ramakrishna sir and Niranjan sir have joined, sir.
good evening, Dr. Ramakrishna. Good evening, Niranjan.
Good evening, sir. Good evening.
Good evening, sir. Sir, what exactly is the carbohydrate-rich fluid, sir, you are using?
So
Is it
basically
plain
now,
glucose or?
Allah, we can actually customize it, but now there are proprietary preparations that are available, which will, which is available in 200 and 400 ml sachets, and that will, basically you give it and they are clear fluids, so you give it 2 hours before surgery, and definitely that is known to reduce the insulin resistance and also reduce the length of stay in the hospital. in patients.
What it
Whether-
contains? What are the
It
contents of that?
just glucose.
It can be
Glucose.
simple glucose water also we can give,
Yeah,
or
yeah.
tender
Just
coconut water or whatever. Carbohydrate loading.
tender
Oh.
coconut water with some added sugar or glucose into it, anything, and but proprietary preparation will just contain glucose only. Maybe
Like
you can
this
blend
electrolyte solution, ORS, those can also be given.
But
ORS
that will not have generally that much of carbohydrates.
carbohydrate, it will not have
It
much
is more of electrolytes. So those are not required.
Okay.
So now let us move on to nutritional assessment as per the ASPEN guidelines. So the important thing is again the stressing on thorough history and clinical examination. There are 4 facets to it: anthropometry, diagnostic tests, and dietary assessment. So these are the 4 facets of nutritional assessment. So now we come to weight loss and malnutrition. There are 3 types. One that is starvation related, whether the starvation is patient because of their not able to, loss of appetite, unable to eat, vomiting, persistent vomiting, or their cachexia due to the cancer they have, all these conditions, or inability to absorb whatever they are eating. This is usually a chronic weight loss, and it is not inflammatory. Next one is acute injury and disease related, which is inflammatory weight loss, and chronic disease related, for example, tuberculosis, or even for that matter, cancer, other medical illnesses, muscular dystrophy, and things like that, motor neuron disease. So there, it is chronic inflammation which causes weight loss. So coming to history, apart from the routine history of everything that about the particular disease, I'm only concentrating on the nutritional history. You have to ask for any rashes, mouth ulcers, dryness of skin or dryness of eyes, loss of night vision, hair loss, swelling of limbs, poor wound healing or tingling and numbness in the periphery, factors that affect the oral intake like dental problems, ill-fitting dentures, oral problems like ulcers or mouth, there is atrophic inflammation of the tongue, glossitis, and things like that, and difficulty in swallowing because of whatever, whether it is neurological or any esophageal problems, and then nausea, vomiting, reflux, significant reflux, bowel disturbances in the form of either constipation or diarrhea or alternating constipation diarrhea, abdominal pain, bloating, and distension. So these are things you have to ask. And then coming to history, past history is extremely important. You have to ask what happened in the previous surgery, length of stay, and all these details about if at all the patient has had previous surgery, any major complications. And so past history, as we all know, is important. And menstrual history, especially in women, including oral contraceptive intake, because oral contraceptives are known to reduce absorption of certain vitamins and essential nutrients. So it is important to know about long-term oral contraceptive intake, and ask the patient about their normal physical activity and exercise pattern, alcohol, smoking, and drug history. The drugs are, I'm talking about recreational drug and also medical, the prescription drugs. So those are also extremely important. Socioeconomic condition of the patient, and for example, if the patient is very poor, they may not be able to afford certain nutrients and they may be malnourished because of that. And family history, again, family history with especially psychiatric and psychological illnesses and stress related disorders, and also some of the conditions where malabsorption is a problem that runs in the family. So family history is again very important. Coming to physical examination, look at the emaciation, weight loss, and also muscle loss. This is the sarcopenia. So again, that is extremely important. See why sarcopenia is important and how it is related to insulin resistance and post-operative recovery is, as soon as the patient undergoes surgery, there is onset of insulin resistance and there is hyperactivity of all the stress hormones. So what all these cause is significant breakdown of the muscle protein and loss of muscle, and insulin, which would have helped in building of the muscle because it actually helps in protein formation rather than degradation, and because there is insulin resistance, so there is unabated and unchecked muscle loss. And as I said earlier, there is about 5.5% of muscle loss in 2 days, and about 15% of muscle loss within a week, and up to 30% of muscle loss in 2 to 3 weeks if the patient is in the hospital. So, and what it does is basically loss of muscle will obviously make the patient weak and they are not unable to walk. And also you have to remember the muscle loss also affects the respiratory muscles, and hence their inability to breathe properly and strongly and cough, and hence retention of secretions, and that leading to atelectasis, pneumonia, inability to breathe, all these things. So it has, and then if the muscle is not working, you can have DVT and pulmonary thromboembolism. So all these things contribute to post-operative morbidity and sometimes mortality. So sarcopenia is a very significant problem and no less related to nutritional supplementation, and hence sarcopenia has to be addressed by both physical activity and exercise in the immediate post-operative period and proper nutritional supplementation. Vitals, you have to check the vital signs, especially fever also. Feeding devices, if the patient has already been on any feeding device like a nasovaginal tube, nasogastric tube, PEG tube, or even parental nutrition, Hickman or the lines, central lines. You have to look at all that. Then look at the eyes, oral cavity, skin, hair, nails, and extremities for edema, rashes, loss of nail, or koilonychia, pigmentation, all these things, and systemic examination has to be completed. Coming to anthropometry, we look at the height, weight, and BMI, mid-arm circumference, then the mid-arm muscle circumference, which will be mid-arm circumference minus 3.1414 into triceps skin fold or any bicep skin fold thickness. So you have to measure the triceps, biceps skin fold thickness, sometimes even pelvic skin fold thickness is also measured, but any of them you have to, and that is a formula that will give you the mid-arm muscle circumference, which is again very critical. Basal metabolic rate has to be estimated in certain specific patients. What are the laboratory tests that you usually do? This is again only specifically, this will be general also, but CBC, blood urea nitrogen, creatinine, and LFT, glucose, lipid profile. Especially in malnourished patients, lipid profile will be grossly altered. Albumin is preferred, but what happens is albumin is it can also be an acute inflammatory response investigation, and hence albumin also has a half-life of up to 20 days, and hence it may be less reliable compared to pre-albumin. So hence, as far as nutritional assessment is considered, pre-albumin is better, transferrin and retinol binding protein. So, and then micronutrient levels as and when described, as and when required. For example, you can check for all of the magnesium, selenium, cadmium, and then all the vitamins, vitamin D, vitamin B12, all of these things have to be assessed, iron levels according to the requirement of the particular patient. Now, there are also body composition studies, which I would urge you all to go and read up. But what are the bioelectrical impedance? There is an equipment which can be done at the bedside. So basically, the equipment is applied to the arm or leg, and then it has different readings for fat and for muscle and for bone and things like that. So based on that, you can assess what is the composition of the particular person, how much muscle mass he has, how much fat he has, and things like that. The most scientific but very expensive study is the DEXA scan, which is dual energy X-ray absorptiometry. And the DEXA scan will give you the exact composition, but it needs obviously a special equipment, and also it is expensive. So DEXA scan to be done in indicated patients. Creatinine height index, again, this is not extremely sensitive, but it is one of the things. The you measure 24-hour urine creatinine, and then calculate the creatinine to height index, and this is supposed to give you the body composition statistic. And in select group of patients, you can do a CT or a MR scan to assess the body composition, especially CT scan done at the level of the third lumbar vertebra. So the third lumbar vertebra is supposed to show the muscle mass in the back and in the abdominal wall, and basically it will tell you, is there fat deposition in between the muscle layers, or in the surrounding tissue of the muscle, and the ratio between the muscle and the fat can also be, and that is supposed to be the most reliable at the level of third lumbar vertebra. I'm not sure why that is, but that is what is advised, but rarely done CT and MR scan to assess the body composition. Now, what are the factors affecting nutritional status and energy requirement? There are physiological, pathological, and psychosocial. Physiologically, age of the patient, sex of the gender of the patient, growth. The patient is in the growth phase, then there can be nutritional deficiencies. Pregnancy, obviously, and lactation, and physical activity. So, physical activity also affects the nutritional status of the patient and energy requirements. Pathologically, genetics, infection, malignancy, medical and surgical illnesses, surgery itself, trauma, and medications that you take. Psychosocially, the cultural and religious beliefs, certain cultural, prevent, consumption of certain things, and hence that may affect the nutritional status. Eating disorders like bulimia, or and things like that, where patient vomits persistently, or they have excessive eating, or reduced eating. So all of this, the psychological disorders, and patients who are addicted to alcohol and substance abuse, such patients are generally found to be nutritionally depleted. So what are the screening tools and assessment tools that are there for surgical nutritional assessment? So there is what is called as malnutrition universal screening tool, called the MUST, mini nutritional assessment MNA, which has 18 domains, mini nutritional assessment short form, which has 6 domains, subjective global assessment, which is called SGA, and clinical in critical care ill patients, critical care patients, and there is something called Nutric score, or the nutritional risk uh, assessment score, which is devised in 2002. That is supposed to be better, especially in patients who are in ICU and critical care. Now let us go through these individual screening tools. MUST was proposed by Bapen in 1992. It takes these domains, body mass index, weight loss over the last 3 to 6 months, impact of acute illness, and overall risk of malnutrition is then assessed by using these 3 factors. The scores are given for all of these. I think you can, there is no need for me to go in detail about this, because it is available readily, and ready-made calculators are available. If you just put these factors in, it will give you a score. So the overall 0 is low risk, 1 is medium risk, and 2 or more is high risk. Patients have high risk of malnourishment or already very malnourished. Coming to mini nutritional assessment, the long form has 18 domains, and it takes about, so it's mainly a questionnaire, and it takes about 10 minutes to fill up. Short form has 6 domains, and it takes 3 minutes. So what you can do is as use the short form as a screening tool, and if the patient is found to be malnourished, you can then go for the long form or other forms of assessment. The nutritional assessment, less than 17 points, the patient is malnourished. 17 to 23.5, the patient is at risk of malnourishment, and 24 to 30 score is considered to be normal. Again, it is a very well studied tool, and well what we call it, it has been validated very well, and it has a specificity of about 98%, 96% sensitivity, and 97% predictive value. which is excellent. So this is one of the most popular nutritional assessment tools. The next one is the short form, which is the mini nutritional assessment short form. It takes, these are the domains: food intake, weight loss, mobility, stress and disease, neuropsychological problems, and body mass index. 0 to 7 of the score is considered malnourished, 8 to 11 at risk, and 12 to 14 is normal. So all these are very easily done and doesn't take much time, and it should be practiced regularly. Coming to the next one, which is selective global assessment. This was Dexter in 1982. He proposed this. It is the advantage of this is it can be applied to all groups in all settings. That is, patients in the hospital, patients in nursing home, patients in the outpatients, patients in for example, patients who are in daycare centers. So any setting you can apply this, and the domains that are considered are medical history, change in food intake, gastrointestinal symptoms, functional capacity of the patient, underlying disease and disease severity. So not only is the underlying disease, but the severity of the disease is also given credence, and physical examination including the muscle mass assessment, subcutaneous fat assessment, and peripheral edema and ascites. So all of this, it gives you a score. It's a quantitative test and gives you a score of three things, which is subjective global assessment A, which says the patient is well. Subjective global assessment, patient is moderately malnourished. Subjective global assessment C is severely malnourishment. So these are the tools. Now coming to the calculation of basal metabolic rate and energy requirements. The Schofield equation, which was introduced in 1982, has stood the test of time. And so the basal metabolic rate is calculated, and so this has a formula. So basically, I don't think we need to know the formula, because if you put the Schofield equation, and you will know all the height, weight, and everything. And if you put it into the Schofield equation, it will give you the basal metabolic rate. So it depends on the age of the patient, the gender of the patient, physical activity, and so on. So hence, no need to remember this, but we should know that Schofield equation is extremely important, one of the main ways of assessing the basal metabolic rate. And next one is the energy expenditure rate. This varies with, again, age, gender, height of the patient, weight of the patient, and physical activity. Again, physical activity is also calculated using the multiplication of basal metabolic rate. That is, in a patient who is a sedentary, female who's just does sedentary activity, you multiply BMR by the factor of 1 to 1.45, and that will give you the physical activity of that particular person. And in sedentary males, you multiply that by 1.7, and you can go up to 2.46 in patients. For example, patients, persons, men or women who are working in army, or athletes, men and women stationed in very high altitudes and cold situations. So this can be multiplied up to 2.46 or even 2.5. So the basal metabolic rate goes up as the activity levels increase. So that can be calculated, and physical activity again has to be calculated. Why is that important? So to calculate the daily requirements of the patient, normally it is considered that protein you need 1 to 1.5 grams per kg per day, or if you are talking about nitrogen, 0.15 to 0.2 grams of nitrogen per kg per day. So that will amount to between, in a 70 kg person, it will amount to between 70 to 100 grams of protein per day. So that is the daily requirement. What is important is, though protein does give you 4 kilocalories per gram of protein, you don't consider the calories that are derived from protein as the daily intake of the patient, because majority of the protein that you take will be utilized in the body building activities and repair activities that goes on 24 hours in the body. So generally protein is used to make up hormones and bone and also repairing all the dead tissue, making new tissue. So protein is not considered as part of the nutritional intake of the patient, though it does give you 4 kilocalories per gram of protein. Carbohydrates, the requirement is 3 to 5 grams per kg per day, which again goes up to, so that is in a 70 kg person, it will be between 250 to 350 grams. So that gives you about between 800 and 1000 kilocalories. Fat is zero point 0.8 to 1.5 grams per kg per day. So that will give you in a 70 kg person 70, and fat gives you 9 kilocalories. So it will give you about 600 to 700 calories per day. So the ideal diet, though there are lots of these fat diets that come in, but the ideal diet, this has been prescribed by all the nutrition, Aspen, Baypen, and everybody, all the nutritional authorities in the world, that your ideal diet should consist of 45 to 65% of carbohydrates, 20 to 35% of fat, and 10 to 35% of protein. So that again varies according to the needs of the patient activity. And the calorie intake generally prescribed is 1800 to 2500 kilocalories. See, there were days when patients who had burns, patients who are septic, patients who are in the post-operative period with hypercatabolic state, where their catabolism would be to the tune of 3.5 to 4.5, even 5000 calories. They were expending that kind of calories per day. There was a tendency to chase this amount of calorie that was being utilized by the patient. That is, you give them as much they are losing, and that had its own problems, because you to give them that kind of calories, the hyperosmolar solution that you had to use would cause a lot of metabolic shifts and cardiac and pulmonary and other complications, and it was actually counterproductive. So the dictum became obligatory or compulsory under nutrition. So which means you don't chase the hypercatabolism, because once the source of hypercatabolism, which is either burns or inflammation or infection and patient's general condition, as it improves and once the source is tackled, the catabolism will come down. But so what you have to do is to give them their daily requirement as that you have assessed according to their body weight, maybe a little more of protein, because you need protein for bodybuilding and the repair activities, and hence you may want to give them a bit more protein. So which is why the requirement is 1 to 1 point. Normally it is 1 gram, but in very sick patients you may go up to 1.5 grams of protein. So the calorie intake, in patients who are sick should not be high. It should be the normal requirement, which is 1800 to 2000 kilocalories. So basically, if you put it to a body, body weight terms, it is between 25 and 35 kilocalories per kg per day. So that is the calorie intake that is required in every patient. So remember the term 25 to 35 kilocalories. And the daily routine of the patient, daily activity, sleep pattern, leisure pursuits, patients who are skiing, or patients who are surfing, or patients who are long-term athletes and marathon runners and people like that, with high cyclists, high degree of activity, obviously their calorie requirements increase. And obviously it depends on the BMR also of the patient. Physical activity levels, that as I told you, the PAL is calculated according to the all the activities the patient does and their sex and gender and age and all that. And calorie intake is adjusted to the total energy expenditure. So the total energy expenditure is calculated by all of these things, and then you have to adjust it. So if the patient is, for example, just before the marathon, running marathon, you obviously cannot sustain on his usual requirements, we will have to step it up at that time. So this, I think, I have come to the first part of the nutrition. This is all about the need for nutritional assessment and nutritional supplementation, the current evidence for that, and then the what happens if the patient is malnourished, and then also how do you assess nutritional status of the patient. So this I will stop here. Now let us have some questions before we end. So in the next class I will concentrate on the enteral and parenteral nutrition and immunonutrition. Questions and clarifications and comments.
There are no questions, sir.
Ah,
But
comments. Did you find it useful? Was it boring?
yes,
Too
sir.
boring?
Very useful, sir. The whole the stepwise approach to even pre-assessment and what all we are going to expect. It was very crisp, sir, and clear explanation. Even
And
the
lots
methodology of all the investigations. Yes, sir.
very informative, sir. We learned a lot, like a lot of things which we never know, which even small assessment and pre-operative rehabilitation or optimization, how it can improve post-operative outcomes, all these things was very informative, sir.
Ramakrishna sir?
Yes, sir. It was a very nice lecture. Quite exhaustive and informative. My question is how exactly you measure this or quantify this sarcopenia? That's one thing. And do you do all these things routinely in all the patients, or only those patients who are going to have major surgeries, means super major? May
Sir,
not be.
yeah, so basically what they do is measure the, for example, they have this, as I told you, the measurements, DEXA scan, and then the bone absorptiometry, CT and MR scan. So those things can quantify the, loss of muscle mass. As I said, it is generally a guide that, on a day, if you are immobile, you lose about 3.3% of the muscle mass, and for 2 days it is about 5.5 to 6%, for a week 15%. So basically the idea of understanding sarcopenia is what are the implications of sarcopenia. So sarcopenia will, definitely derail your post-operative recovery, because patients become weak and immobile and they don't walk around. And also the, the breathing, respiratory, because sarcopenia does not affect just the skeletal muscles of the periphery, it also affects the respiratory muscles, which are the obliques and the rib, the intercostals and things like that. So hence, it is extremely important to be aware of sarcopenia. And why does sarcopenia happen? It's because of lack of understanding of the nutritional requirements of the patient. So if you supplement them right from the days, even pre-operatively if they are at risk, or pre-operatively if they are malnourished, you have to ensure that their nutrition status is brought up to speed for a period of between 7 to 14 days, depending on how severe is the nutritional depletion. And in the immediate post-operative period, continue the nutritional supplementation and support and nutritional therapy, so that if you give them adequate proteins, calories, and everything in the right prescribed formula, then because the body you are basically you are treating the essential cause for the sarcopenia. And also, as I said, the patient has to be mobilized as soon as possible. And also their, in diabetics and patient, the uh, this one insulin therapy has to go on. And so with all of these things, you are reducing the sarcopenia. It does happen a little, but you can reduce the extent of sarcopenia, and you can also reduce the ill effects of sarcopenia.
No,
It is
all these are required routinely in all cases like
No,
appendectomy or
it
routine
is
lap
not required.
hernia.
No, it is not required in all patients. That is why a quick preoperative assessment of patients will give you an idea. See, the thing is, as I said, about 27 to 50% of all patients. I'm not talking about India. I'm talking about the entire world. Even the very developed countries are malnourished, whether they are obese or whether they are undernourished. But 27 to 50%, which is a very significant number. So hence, a quick nutritional assessment in all of them is mandatory, and hence when you recognize patients who are at risk of malnourishment or who are already malnourished, then you have to address problems in them. But generally, patients who come in for an one-day appendicectomy, and they would anyway they will be mobile and they will go home the next day, so they are not at risk. And if you find them they are at risk, you can give them oral and supplementation when you discharge them. But when patients are likely to stay in the hospital between 5 and 7 days or longer, then these things become even more important.
Yes, sir. Thank you.
Niranjan, your thoughts and questions, if there are any.
Sir, no questions, sir. It was excellent and comprehensive coverage of the entire nutrition. It was good, sir.
Thank you. So next class we will concentrate on enteral nutrition, parenteral nutrition, the comparison between the two, the advantages of both groups, and then also immunonutrition. The immunonutrition, what I have covered is just the level of evidence and the recommendations of the Aspen and Aspen group. That was the about 36 recommendations. So I have covered what is there in that. I have also shared the articles that cover these things, and also in our surgical WhatsApp group, I have given you the article from the Aspen Congress which happened in 2019 and the consensus statement that has come out of it. And that article has been written by one of our batchmates called Dilip Raj Lovo, who is professor of surgery at Nottingham University, which is very well known for nutritional assessment and nutritional, and they are one of the leaders in nutrition. So the article is also extremely good. I think it would, all of you please read that. It is a very good article. So with that I will end the class. Thank you all for patient listening. Good night.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.